This case study presentation is an opportunity to present an analysis of the types of technology used in an acute care nursing. For this presentation, I have decided to apply the scenario of case study 1, assuming the role of a registered nurse in a remote hospital, working an evening shift with an enrolled nurse, with a GP on call, as well as the hospital's director of nursing. The scenario involves a 55-year-old man inbound via ambulance service with chest pain. The estimated time of arrival to hospital is 15 minutes. The paramedic has conducted a 12-lead ECG, which shows an ST-elevated myocardial infarction. The patient's observations communicated by the paramedic are a GCS of 14, blood pressure of 190/90, heart rate of 112, respiratory rate of 32, SpO2 of 96, and 9 out of 10 pain. The patient must be arranged for an urgent transfer to a tertiary hospital, however, aeromedical retrieval services are more than 3 hours away. A myocardial infarction happens when one of the coronary arteries becomes occluded. This leads to an area of myocardium, which was supplied blood and oxygen by this artery, experiencing ischemia and necrosis, causing crushing chest pain, which may radiate to the left arm or jaw. ST elevation on an ECG indicates myocardial injury beyond ischemia. This presentation will provide a brief step-by-step description of the management of the patient in question. The focus of this presentation will be the technological tools and services used in the management of the patient condition, as well as discussing the future of technology in the acute care setting. The presentation will be divided into 3 stages: the preparation for his arrival, his presentation, and his post-transfer needs. In preparation for the arrival, several important things are arranged. First, the GP is contacted via phone and asked to immediately present to the hospital. GP is required to prescribe medications and to assist in the management of this emergency presentation. The Director of Nursing is also called to provide assistance in this high-risk scenario and to help arrange transfer. The emergency resuscitation bay is checked and it is ensured that it is set up and ready for the presentation of the patient. Contact is made with the aeromedical services. The technological equipment that will be discussed and used in this situation are high-flow oxygen, emergency trolley with defibrillator or AED, and 12-lead continuous cardiac monitoring, automatic observation machine, biochemical markers and the use of iStat machines, radiological imaging, mobile telehealth interface, aeromedical transfer, and mobile applications. On the presentation of the patient, the emergency care cycle is applied. In this time, the patient's level of consciousness is assessed, and an attempt is made to identify the patient so that his records can be accessed. The assessment of his airway, breathing, circulation, and the use of defibrillation if necessary is then applied. The patient's airway is not compromised, however, he breathes at a rate of 32 breaths per minute. His SpO2 is 96% on room air, his heart rate is 112 beats per minute, and his blood pressure is 190/90. His rapid respiratory rate may be due to pain, anxiety, and stress, which additionally exacerbates heart rate and blood pressure. The patient is instructed to take deep controlled breaths and reassured of his situation. Respiratory rate of 32 indicates that he is short of breath. He is exerting too much energy to maintain his oxygen saturation of 96%. He is supplemented with oxygen and that is applied to provide a higher concentration of oxygen saturation to the patient. Easing sympathetic nervous system activity by making the patient feel more calm and safe while conducting emergency care and additionally treating his 9 out of 10 acute pain may reduce the vasoconstriction and increased cardiac workload associated with sympathetic nervous system activity. Oxygen is applied via Hudson mask at 5 liters per minute. He is fitted with an intravenous cannula and administered pain relief, such as morphine. The patient is connected to an automatic observation machine, which will intermittently assess the patient's heart rate, SpO2, and blood pressure. Human mechanical assistance and effort must be used to assess the respiratory rate and temperature. The heart rate and blood pressure should be assessed manually at times to ensure correct findings of the automatic machine. Access to a defibrillator is vital in emergency situations. The AED device is attached to the patient by a 12-lead ECG to gain constant cardiac electrical activity measurement. This will alert health professionals to any immediate deterioration or arrhythmias, and also to recognize any improvement in his condition. The constant tracing of electrical activity will bring attention to arrhythmias such as ventricular fibrillation, to which defibrillation pads are applied, and for shockable rhythms, apply a charge to re-establish effective rhythms. Within a few hours, the ST elevation on an ECG may return to normal. Prolonged ST elevation may indicate ventricular aneurysm. The GP and nursing staff currently attending the emergency situation may have a limited knowledge and experience in reading ECGs. With the use of certain smartphone applications, these professionals may recognize ECG variances. It is important that ECG tracing is reviewed by a skilled professional, as it may assist in determining the location of which coronary artery has become occluded. It will determine if the infarct is located on the inferior, lateral, anterior, or posterior plane of the heart. This is important for the prognosis and the implications for treatment post-transfer. These transmissions may be made available to professionals in the tertiary hospital. A blood test for biomarkers such as troponin and creatinine kinase are important in assisting diagnosis and prognosis. These biomarkers are significant of myocardial necrosis. The non-availability of formal blood testing in remote locations and in emergency situations depends on the use of these portable pathology testing devices. Formal blood tests can be collected, and their bloods must be sent along with the patient when the retrieval services arrive. Use of on-hand pathology testing devices such as iStat machines require training and certification for their use. Ideally, the patient would have angiography. However, in this remote setting, angiography may be not available. Angiography is a cardiac X-ray in which contrast dye, a product which shows up clearly on X-ray, is injected into the vein and reveals the interior aspect of the arterial lumen to identify the site of occlusion. Angiography also establishes resting LVF, or left ventricular function. Echocardiogram may be available if personnel availability allows. Echocardiograms may be done at the bedside with a small device. It is used for the information can be transferred to a cardiothoracic specialist for the interpretation. Echocardiograms assess for segmental wall motion abnormalities and assist in the diagnosis. Patients who have had a myocardial infarction must undergo reperfusion therapy. In a tertiary hospital with a cath lab setup, the patient would have a surgical procedure known as percutaneous coronary intervention, or PCI, a treatment in which a balloon catheter is inserted into the stenotic coronary artery and inflated to facilitate blood supply to the myocardium. A stent may be then placed to prevent reoccurrence. However, in this setting, without PCI availability, the only choice is thrombolytic drug therapy with adjunct antiplatelet and anticoagulant medications. Reperfusion, whether it is PCI or thrombolysis, should be commenced within 90 minutes of presenting to hospital. When this patient presents to a tertiary hospital, he will likely receive rescue PCI or even a coronary artery bypass graft, where a vessel from elsewhere in the body is transplanted into the heart. In small hospitals with limited specialist staff, advice is often sought from larger health facilities to assist rural professionals in the provision of life-saving treatment. Using a mobile telehealth interface, an internet-facilitated video conference call is made to a cardiothoracic specialist from the tertiary hospital. The use of telehealth at the bedside is a powerful technological advance which allows the specialist to visualize the patient and be as present as physically possible. ECG tracings, imaging results, and blood pathology results can be accessed remotely, providing the assisting specialist with important information to base treatment plans on. In remote areas, the confidence of small teams increases with the use of telehealth services, as the specialist can then instruct the team in the patient's management. In some circumstances, the use of telehealth can either minimize the need for transfer to other health districts or communicate recognition for the more urgent need for this transfer to occur. The requirement for aeromedical retrieval services can be identified, arranged, or influenced, and the priority is made in the management of this patient at a high risk. The pre-tertiary hospital delay is experienced by many rural and remote living Australians because of distance may be the biggest barrier to their effective management. Delayed access to specialist care results in an increased risk of morbidity and mortality and exacerbates patients' anxiety. For this reason, as soon as it is identified that the patient must be transferred, this transfer must be arranged with priority. Aeromedical transfer is currently the fastest way to reach tertiary hospitals and specialist management. Using phone services, flying doctors' nurses usually communicate with the nurse caring for the patient for retrieval and receive an update on their clinical condition. Once the patient has arrived to the tertiary hospital, they will have PCI and undergo education, or likely have PCI, and undergo education regarding management of his condition and the potentially chronic condition depending on his level of function now. He will likely receive a visit from a cardiac nurse specialist who will offer education and strategies in management of his condition now. The aim of this intervention is for successful lifestyle modification, things such as smoking cessation, diet changes, stress reduction, increased physical activity, and medication compliance. For educators, the use of multiple formats of educational material, including modern technological tools such as smartphones and iPads, are a powerful tool in engaging patients with health education. Smartphone apps such as My Heart, My Life app from the Heart Foundation, with an easy-to-understand and user-friendly interface, includes recipes, warning signs, educational material, medication information, and medical information for people who have had a myocardial infarction. They're accessible with or without internet connectivity. There are a multitude of other mobile applications which are loaded with health promotion, information, activities, reminders, and peer support networks also. They are updated regularly so they remain up to date with the current best practice. Technology is advancing rapidly, and nurse leaders are at the forefront of these advances. The skills which are going to be highly valued in the future of nursing is the ability to respond to the emerging technology and adapt to changes in practice. The result of recent advances in technology in nursing and healthcare means that the majority of nurses have a positive attitude towards technological advances in health. With further advances, it is expected that specialist services and large cumbersome equipment will be more available in compact forms, which means more accessible tools for the bedside, such as angiography. Proposed advances in telehealth and robotics aims to eventually have remote-controlled robotic equipment controlled by specialists in tertiary hospitals, capable of performing life-saving surgical interventions such as PCI prior to transfer from remote locations. This early intervention will result in better prognosis for patients, such as our case study. Electronic health records are a computerized and nationally available method of keeping patient records. Many rural and remote hospitals do not have any form other than paper records, which must be copied, faxed, and emailed in providing correspondence with other health districts. The rapid accessibility of electronic health records for health professionals during telehealth can help provide a more reliable and accurate sharing of information between professionals. It will improve the coordination of care and result in better communication. Uploaded information into an electronic form will be accessible by professionals locally and remotely. All information will be uploaded with the ability to be translated into quantitative graphical information for simpler recognition of trends. This presentation has presented a discussion of the current technological tools used in the management of patients with ST myocardial infarction in the acute stage, as well as in their follow-up, education, and health promotion. It has considered the future of technological advances in healthcare and the impact that they will have on the health and well-being of patients, especially those in remote locations with urgent specialist needs. As nurses, we're at the forefront of new technology. It is in the best interest of nurses nationally to keep up to date with these advances. Thank you.